Hello, everyone. Welcome back to the Pedestrian and Bicycle Information Center's Health and Transportation webinar series. You're tuned in now for part 4 of our 5-part series. I hope that you have been able to attend the first 3 episodes and that you plan to join us again tomorrow for sort of a final discussion on policy. We're excited, though, that you're here today because we're going to really get into some nitty-gritty detail about how we can plan and prioritize transportation projects for health and really elevate health in our priorities and reflect that in the types of projects we do. And so we've got a great panel of experts who are going to share their stories and their experience doing this work, specifically in Virginia. You'll hear from a lot of them. I don't want to hold up much of their time, so I want to get into some housekeeping right out of the gate here. And tell you a little bit first about the series that you're in, the Health and Transportation webinar series. We're on October 27th here, planning and prioritizing projects for health. This is a view of the other episodes we had planned in this series. As we sit on this slide for a moment, there are just a few housekeeping items that I want to remind you about. As webinar attendees today, you're not going to have the ability to speak over the phone, but you will have the ability to submit questions and comments to us using that questions pod in the GoToWebinar system. Please send those whenever you have them. We are planning to hold a Q&A session at the end, 20-25 minutes or so. We'll ask our panel to weigh in on some of the questions you're asking. So please ask those at any time. We'll hold that time for discussion at the end there. If you are looking for the archive for today's webinar, we're going to post a recording tomorrow or maybe even later this afternoon. We've already posted a PDF copy of the slide presentation. I can share that with you momentarily in the chat pod. We're also going to be sharing a little bit of information following the webinar today in a follow-up email on how you can claim professional development hours for the webinar, how you can get a certificate of attendance. If you're a planner and you like to typically claim AICP credits, we have had this webinar approved for those, so you can go to their website and log those as you normally would. We're also providing a live transcript of today's webinar. If you need that, I'll be sending the link out momentarily. It's also on our webinar archive page at pedbikeinfo.org. I also just want to encourage you one more time, if you haven't seen these other episodes in the series, please check our website. The video recordings are up for episodes 1 through 3. You still have a chance to register for our discussion about bringing health to transportation policy tomorrow afternoon. We know that health and transportation intersect in many different ways, and that transportation infrastructure and services and the related policies and designs have been identified as key factors influencing or determining our health status. And part of what motivated this series came from our work on a recent NCHRP report that you see here on the screen that produced a research roadmap for transportation and health. Lauren Blackburn will be sharing some more detail about that project shortly, but I wanted to share some of the questions that we asked in that study and questions that continue to be raised and are being discussed throughout this series, such as, how are health and equity defined within the transportation community? How can transportation practices impact health? In what ways are transportation agencies considering health in current practices? And finally, what partnerships, research, and other resources are needed to really improve practice? And these are some of the many pathways that transportation practitioners can take to improve public health. And in the series, we're going to be discussing the ways that transportation agencies are examining who is at the table and has power in decision making, how they are partnering with other organizations, integrating data, changing processes and practices related to project selection, and forming more health-oriented policies. So today, we're really going to be focusing on and hearing about strategies that transportation and health agencies can use to incorporate health priorities in project prioritization activities. I want to take a moment and introduce you to our panelists today. First, joining us again as a moderator for the session is Sagar Shah, who is the Manager of Planning and Community Health at the American Planning Association. In this role, he creates tools, training, and educational materials to help local planning practitioners integrate health and equity into their planning practice. In his more than 15 years of academic and professional career, he has worked on multiple applied research, community-based research, and basic research projects. Sagar's research interests include investigating the role planners play in creating healthy communities with an emphasis on health equity, and he is a national leader on this topic. So we're excited to welcome back Sagar Shah. Lauren Blackburn is also with us today. She is a senior project manager with VHB, Lauren has over 17 years of experience in multimodal and long-range planning and is based in VHB's Raleigh, North Carolina office. Lauren's key areas of interest are in bicycle and pedestrian transportation, comprehensive planning, roadway safety, and community health. And prior to joining VHB, she worked for the North Carolina Department of Transportation as the director of the Division of Bicycle and Pedestrian Transportation. Previously, she was the planning manager for the town of Davidson, North Carolina. So we're excited to have Lauren here with us today. Mark Cole was also joining us. He is the State Highway Safety Engineer for the Virginia Department of Transportation, leading VDOT's highway safety programs. For over 2 decades, Mark has held leadership positions with state and local transportation departments in Virginia and North Carolina, with a focus on the planning, design, and construction of transportation projects that serve all modes of transportation. Now, specific areas of interest, professional interest and passion include traffic safety, urban street design, and transportation program and project management. So we're delighted to have Mark with us. Stephen Reed is joining us as well. He has over 30 years of experience with traffic operations and safety engineering and multimodal transportation planning projects, research and management. He previously conducted project consulting and research work in London, the UK, Ontario, Canada, and Virginia. At VDOT, he presently leads the Highway, Bicyclist, and Pedestrian Safety Planning Program. He's an active member of VDOT's Traffic and Safety Research Technical Advisory Committee, TRB's Highway Safety Performance Committee, and he's the chair of AASHTO's Highway Safety Manual Steering Committee. So we're really excited to have Stephen joining our panel today. Finally, we're joined by Justin Crow, who's the director of the Division of Social Epidemiology at the Office of Health Equity of the Virginia Department of Health. And prior to joining the Office of Health Equity, Justin served as the Deputy Director for the Virginia Healthcare Workforce Data Center and the Deputy Executive Director for the Board of Health Professions, both with the Virginia Department of Health Professions. So I don't want to take any more time away from our panel, and I'd like to first turn things over to Sagar Shah, who's going to kick things off, serve as our moderator today with a brief presentation. So Sagar, please go ahead and you should be able to share your screen whenever you're ready.
Perfect. Can you hear me okay?
Yes, I can. You're all set.
Okay, perfect. Hello, everyone. My name is Sagar Shah, and I work at American Planning Association. As Dan already mentioned, I just want to say thank you for joining us today. I know we are all going through challenging times. It seems like one day I feel that nothing is going to go wrong, but then yeah, it just gets worse and worse every day. So thank you for spending some time of yours and joining us for this session. I just want to thank the Pedestrian and Bike Information Center for inviting me to moderate this amazing session. We have great speakers, and I'll ask them to talk about their work in like 5 minutes. I'll just talk a couple of minutes. I'll talk about the work that I do at APA, and then I hand it over to the main speakers of this afternoon. So I manage the planning and community health program at APA. So I'm based in the research department at American Planning Association, and we sort of do funded research and unfunded research. And I'm placed in the funded research, focusing on integrating health and equity into planning practice, helping our members working at local levels to do just that. Traditionally, we have worked on various projects, but mainly focusing on active living, food systems planning, health impact assessments, health in all policies approach, and similar projects. Recently, we have been diversifying and thinking a lot about rural health, health about small communities and rural communities. Also thinking about the connection between climate change and health, and of course, how can emerging technologies would impact health. So we've been thinking about new topics related to health. We usually adopt 3 mechanisms to work on projects, especially funded projects. We do applied research, where we look into the gray literature, the academic literature, and then try to create tools for our members, which are practicing planners. We also do place-based work, where we work with communities, or sort of sometimes it is like train the trainer. So we are working with planners, working in the communities, providing them technical assistance or providing them some type of funding to achieve a goal that they have to improve the quality of life or health of the community. And then the third thing we do is, of course, we create a lot of trainings, educational programs, educational courses, etc., on specific topics that sort of are very relevant to planning practice. So yeah, with that, I'll just a couple of couple of sentences about today's session. The first one is I for APA, health has been an important topic since last 10-15 years. The Planning and Community Health Center was created in 2008, and we have been going strong since then with funding from a lot of national agencies and foundations. But yeah, it has been an important work that APA has been doing. I personally have bias towards health, of course, and I believe that all policies, health policies, and we have worked a lot on like health in all policies approach, like how health should be not only in transportation but beyond that, like how health can be thought about in everything that planners do. Health impact assessment is another tool which encourages planners to think about health in different projects and programs, plans that they work in. So I just want to highlight some of the connections between health and planning. And the second thing I would like to mention is cross-sector collaboration, which is very important to our work. I'm very glad to see Department of Transportation and Department of Health coming and talking about their projects and their collaborative work today. But I would encourage all of us to work beyond that and work with other departments in your city, at local level, at state level, wherever you are working. It is very important that we work together to create equitable and healthy communities. So yeah, this little bit about my work and a couple of sentences on today's session. I would like to hand it over to Lauren from VHB to talk about her work. Back to you, Lauren.
Thank you, Sargar. Dan, can you hear me okay?
Yeah, Lauren, you're a little bit quiet, but I can hear you.
Okay. All right, better?
Better. Thank you.
All right. Thank you, Sargar and Dan. I'll also be brief. And really what I want to do today is just give a bit of a more background on that NCHRP project that Dan first mentioned and its relevance to what the partners at Virginia Department of Transportation and the Health Department are going to talk about in just a moment. As Dan mentioned, the report 932 is a synthesis of many different gaps and research needs that the team, VHB, as well as the University of North Carolina Highway Safety Research Center, as well as Sagar with APA and others, we worked together to look through some of the current research, but to also identify some of the outstanding research gaps and needs. If you're not familiar, you can find the report online if you just look for NCHRP 932. The process that we followed was very wrapped around the transportation process. Dan talked about those pathways to health. And when we were identifying those gaps and needs, we wrapped it around these central processes that oftentimes help form transportation decisions. So starting at that highest level, community engagement and using data, you're going to hear a lot today about how VDOT as well as the health department have collaborated to integrate health data into early planning stages as well as to ultimately to project scoring and prioritization. This collaboration between VDOT and the health department is really centered around those planning stages and prioritization. So we're going to talk a lot about how health data was successfully integrated into safety planning for VDOT, but also into some of the ultimate project prioritization. And we want to see this kind of model replicated in all transportation decisions. In the research roadmap, there are many gaps and needs, hundreds of them in fact. Some of these have been developed further into what were more extended research need statements, but many of them centered around this whole need and notion of integrating health data into other decisions. So for example, a major gap was the lack of guidance on how to integrate health data into prioritization, programming, and other transportation processes. And in fact, several of the more specific needs were to talk about what MPOs as well as state DOTs are currently doing to integrate that health data. So I think what Virginia has been doing is a great example of that. So ultimately, what we hope to see is that the health data is going to be considered early on in those planning stages. So what you're going to hear Virginia DOT talk about is after a couple of iterations of a planning process that they worked through, they found the health department data to be a really useful information and input to an update to what their pedestrian safety action plan called for. And then later on, you'll hear Stephen talk about how that same pedestrian safety planning effort continues to leverage on that health data, and then it's going to circle back into seeing those projects integrating health into some of the final decisions so that we can see better health outcomes as well as pedestrian safety outcomes, which really meet many of the different objectives between the two departments. So again, I think that what they're going to share is an excellent example of what the NCHRP project set out to do and hopes to see more research and examples come out for. So that's a really brief introduction of what I can see as some of the connections between these different projects and data sources. So look forward to hearing more from VDOT, and if you all are looking for it, again, NCHRP 932 has all those other research gaps and needs. And I think this will be a turnover to Mark.
Okay. Thanks, Lauren. I appreciate that. And Mark, coming to you now. I should be able to take over the screen. I'll let you know when we see it.
All right, how's that, Dan?
You're all set, Mark. Thanks.
All right, awesome. Well, we're certainly happy to be here with everyone today to talk about Virginia's Pedestrian Safety Action Plan and how we've used some health data from the Virginia Department of Health to assist us in those efforts. Back in 2016, Virginia published our first Virginia Pedestrian Crash Assessment, and what that was a deep dive into our crash data that involved pedestrians. We took the crash data that we received from our Department of Motor Vehicles from the police crash reports, and then we added a lot of VDOT data that consisted of information about road design characteristics and environment. We also added a lot of data by using Google Street View at the locations where we've seen deaths and injuries occur involving pedestrians. So we took that information, compiled it together, and found some very interesting trends, and published our first crash assessment back in February of 2016. And since that time, we've really been looking to leverage that information to really take that data and put it into action. So in November of 2017, we updated that initial report to include a couple more years of crash data. And then in May of 2018, we used that crash data in the crash assessment to develop our first statewide pedestrian safety action plan and online mapping tool. That's been very valuable for us to help explain to decision makers and others what our prevailing pedestrian safety issues are in the state, especially in regards to infrastructure. And so we took that information from the PSAP and used it to get buy-in and support for an initial $8 million of PED safety projects in November of 2018, and then another $25 million in October of last year, focused on making some pedestrian crossing improvements at traffic signals. And then finally, in February of this year, in 2020, a lot of what we're going to talk to you about today is our integration of health data into our pedestrian safety action plan. And so in February of 2020, we updated our PSAP to include some new analysis that includes some health information from our Virginia Department of Health. So to just start at the very beginning, we first focused on the crash data and trying to really understand what the environmental factors were that were in place where we were seeing pedestrian deaths and injuries on Virginia's roads. So we mentioned that we first published this report back in 2016, and then we've updated it twice since then, both in 2017 and earlier this year. And it uses a variety of data sources to try to understand what's going on where we're seeing pedestrian crashes in Virginia. And a lot of that information that I'm just going to highlight on the next few slides are things that we may have anticipated, but there are also a few surprises. So one of the key findings deals with land use, and this is something that we expected in some ways, but we really didn't know to what extent land use would play a role in where we are seeing pedestrian fatal and injury crashes. But in almost 80% of the locations where we have a fatal pedestrian crash, we determined through our work that we have pedestrian land uses, such as residential or commercial areas or recreational land uses. You can see from this photo here at the bottom of the slide a situation that we have throughout Virginia, where we have a large neighborhood on one side of a very wide suburban road. We have sidewalks, we have ADA ramps, we have a traffic signal, but we don't have pedestrian countdown signals or crosswalks to help pedestrians make a safe crossing across the roadway. And so about 80% of our fatal pedestrian crashes and 90% of our injury crashes involving pedestrians occurred in locations similar to this, where we have land uses along the side of the road where people want to walk between. And looking a little closer, what we also were able to tell is what kinds of intersections or non-intersection locations were present where we're seeing our deaths and injuries. So on the left side of the screen here, you can see where Virginia's fatal pedestrian crashes happen. Almost 80% of our fatal pedestrian crashes in Virginia occur at locations that are not signalized intersections. Almost 63% occur at either unsignalized intersections or mid-block locations. So those locations are really two areas where we're focused on currently, trying to change policy and make some shifts in how we do our business so that we can ensure we have enough adequate crossings for pedestrians to be able to make it across the street safely. Also at locations where pedestrians die in Virginia, in addition to almost 90% of the time being while they're making a crossing of the road, at those locations, almost 70% of the time, there's no marked crosswalk available. And we looked not only where the crash occurred, but we looked 500 feet upstream or downstream on the roadway, and 68% of the time, we didn't find any marked crossings where our pedestrians died when crossing the roadway. So this is something that was a surprise to us. I mean, we anticipated that we would have a number of locations without crossings, but this percentage was actually a pretty big surprise to us and has helped us decide some of the areas we need to focus on to ensure that we have marked crossings in locations that can help ensure safe opportunities to cross the road. Another key finding in our work has to do with speed limits. So we were able to look at all the pedestrian crashes over the 5-year period and the speed limit of the location where those crashes occurred. And you've probably seen some of the other graphics and charts that talk about impact of speed on a pedestrian's ability to survive a crash. Well, this is somewhat similar in how we've laid it out. But what you can see is in Virginia, between 2014 and 2018, when a pedestrian was struck on a road posted at 25 miles per hour or less, 7% of those crashes resulted in a fatality. but 93% of those crashes resulted in an injury. As compared to crashes that occurred on roads 50 miles per hour and greater, where almost half of those crashes resulted in the death of the pedestrian and half an injury. So a lot more chance on those higher speed roads that the pedestrian will die as compared to the lower speed roads. In addition, another key finding that we found is light condition and visibility, the ability to see the pedestrian is very key in outcomes of these crashes. So almost 3 out of 4 fatal pedestrian crashes occur in limited light conditions, and that includes dawn, dusk, or dark. In addition, you can see on the lower left side of this slide that the time of year when more pedestrians die in Virginia coincides with our darker months, the months that we're about to enter now here around Halloween and through the holidays, where it gets dark really early during times when we have a lot of folks out walking around, and we have, unfortunately, a large number of deaths. So that was something that came out as very apparent as we did this work. In addition, in the first version of our crash assessment, we did not have transit information because we didn't have access to a statewide transit data layer, but that was an enhancement. And we were really excited that our Department of Rail and Public Transportation had a transit layer that we were able to use for our updates to the crash assessment. And what we found here when we looked at bus stop locations and transit route locations is there's definitely a strong connection between where we see pedestrian crashes in our transit routes and transit stops. So definitely a strong link there, and especially too on our more suburban routes where we have such a issue of higher speed crashes, where we have transit routes, but we may not have other pedestrian infrastructure. This is something that's helped us greatly as we plan where to invest safety improvement dollars. And then finally, something that we're talking about today is the Health Opportunity Index. A little later, you're going to hear in some detail from my colleague Justin Crow about Virginia's Health Opportunity Index, but we use this information to see if there was a connection between pedestrian crashes and the Health Opportunity Index score. And what we saw is that 60% of our deaths and injuries involving pedestrians in the state occur where we have very low or low Health Opportunity Index scores. So definitely overrepresented are pedestrian crashes where we have low and very low Health Opportunity Index scores. And I'm not going to go into great detail, but just to give you an idea as to what the Health Opportunity Index is. It's an index developed in 2012 by our Department of Health as part of our Virginia Health Equity Report. And it's a way of measuring the opportunity for a person to live a long, healthy life. And each census tract in the state gets a score based on 13 different indices that indicate quality of life. And so we were real excited to learn about this data set and to try to use it to see if there were some connections that would help us understand our pedestrian safety concerns in Virginia. And so here's a little bit more information about the HOI that Justin's going to go through later. But there's a composite score that's made up of several different categories to include community environment, consumer opportunity, economic opportunity, and wellness disparity. And so what we see with the Health Opportunity Index is there's definitely differences geographically where folks struggle to live a long, healthy life as compared to to other locations. So I know you're looking forward to hearing from Justin in more detail on this. So using that information and much more that was in the pedestrian crash assessment, we developed our first Virginia Pedestrian Safety Action Plan back in 2018. There are three major parts of the action plan. The first is policy recommendations to ensure pedestrian safety. So we looked at all of our standing policies and practices at VDOT to determine what things really promoted pedestrian safety and what areas we need to focus on because the policies that we have in place don't do a great job of ensuring pedestrian safety. So we're doing a lot of work in this area now to try to make sure our policies really support being able to walk safely throughout the Commonwealth. The second component of this plan is what we're really focusing on here today, and that was a safety analysis to determine what specific road locations in Virginia pose the greatest risk for pedestrians. And then finally, number three, the action plan also includes safety countermeasure recommendations and a toolkit with some great resource material to help folks understand the best countermeasures to use to ensure pedestrian safety. And so to talk about the safety analysis that we did, we really did two types of analysis. One we call crash clusters and the second priority corridors. So the crash clusters are really a density map based on the actual crash locations over a 5-year period. And so you can see there in the graphic, the crash cluster looks kind of like a weather map with a green area shading, which shows a lower density of crashes, which moves to a yellow, and then the most intense density is shown by a red tint in the map. So if pedestrian crashes are closer together, then your heat map is going to look more red than green. And this can help us from a big picture see where some of our pedestrian crashes are focused. But it is really a look back to what has happened in the past in regards to pedestrian crashes. The second type of analysis that we did is called the priority corridor analysis. And we analyzed and ranked all the public roads in Virginia to get our top priority corridors. And the priority corridors are based more on an analysis using data that's available that indicates pedestrian presence or risk, such as speed limit of the road, how many lanes are in the road, what's the population density along the road, is there transit along the road. And now with our current PSAP analysis, as we're talking about today, we've also included Health Opportunity Index as one of the factors in that priority corridor analysis. And so the corridor analysis is predictive. We're trying to predict where pedestrian crash risk is higher so that we can spend our limited transportation dollars to improve pedestrian safety in those highest risk locations. So the original method that we used when we first developed the PSAP back in 2018 included these corridor scoring factors and resulted in 181 priority corridors identified across Virginia. So a high weight, as we did this analysis, was applied to data to include the average daily traffic, posted speed limit, zero vehicle households, and population density. Medium weighting was applied for roadway geometry, such as the number of travel lanes and whether a location is divided or undivided. In addition to urban-rural context, employment density, and proximity to a school. And lower weighting was applied for locations based on the population adjacent to the road segment that was living below the poverty line, whether there had been a crash history involving pedestrians in the past, And also we had some factor in for alcohol-related pedestrian crashes and proximity to a park. But after we learned about the Health Opportunity Index, VDOT worked with our consultant VHB to do some analysis to determine how strong the connection was between the HOI and our pedestrian crashes. And as you saw earlier, we had already seen that we had an overrepresentation of pedestrian crashes in areas with low HOI scores. But VHB took it a step further through the spatial Bayesian analysis, and they ended up finding that the HOI score and zero vehicle households were the strongest factors that also resulted in, so that connected to where we were seeing our pedestrian crashes. So HOI and zero vehicle households had a strong relationship. Employment density came out somewhere in the middle, and then population density was a lower indicator as far as where we might expect pedestrian crashes. And one that was a surprise to us was the poverty density, which we had included in our initial PSAP analysis, but we really didn't see a very strong relationship between the poverty density and pedestrian crashes. So using that analysis, we updated our corridor scoring factors for our 2019 update of the Pedestrian Safety Action Plan. As I mentioned earlier, we now have transit information and know that that's a strong correlation. So we've included transit access as a high weighting in the scoring. In addition to Health Opportunity Index, we moved the posted speed limit information from a high factor to a medium factor. And then we also moved population density in urban rural context from medium factors down to low weighted factors. And we removed the alcohol factor we have been using from the analysis. We also removed the population living below the poverty line because, as I mentioned, the analysis that VHB did for us showed that there wasn't a very strong relationship at all between that data and pedestrian crashes. So another thing that we changed in 2019 is we went from a 2-tier system of priority corridors that we had in the first round to a new 3-tier system. So both our version 1 of the PSAP analysis, both it and our latest updated version include top 0.1% statewide priority, which are the corridors that scored in the top 0.1% in the state. These continue to be our highest priority locations that we're trying to go out and study and address from a pedestrian safety infrastructure standpoint. We also, in both the original and the update, we have a secondary statewide priority that includes the top 1% of scored locations. But new for this latest update is we now have a top 5% priority, which reflects the roadway segments in Virginia that scored in the top 5% of this analysis. What we discovered after we first published the PSAP is that this information has been very useful to others in their planning efforts, and so there was a desire for more locations that have a pedestrian risk. And so we decided to expand the analysis when we did the update to now include the top 5% instead of just the top 1% of locations. So these locations are based on the final score assigned to the road segment, considering all those weighted factors that we talked about. And they're also situated along the state's master linear referencing system network. It also is helpful in that it includes several priority locations in all 9 VDOT districts. We certainly have more locations noted in our more urban districts, but even our more rural districts, such as the Bristol district and Southwest Virginia, have a number of locations that have shown up in our analysis to have pedestrian safety needs. In addition, VHB looked at how the priority corridors measured up against where pedestrian crashes had actually happened for the 5-year period that was studied. And with our update of the PSAP in 2019, we actually determined that we're capturing more of the locations where crashes had actually happened. So that gives us an idea that we're on the right track as far as trying to predict where crashes may occur involving pedestrians in the future. We don't have enough time today to go through all the details of our plan and our map, but I would encourage you to take a look at this website where you can see our PSAP online mapping tool. It includes our crash cluster locations and our priority corridor locations for both version 1 and our recently updated version of the PSAP. You can also download a copy of our PSAP report by clicking here on the splash page. And you can also view some YouTube tutorial videos to show you how to use this mapping tool as well. So with that, the last thing I want to leave you with, and that I always like to include in any presentation like this, is to talk just for a moment about how we're using this information. So we're very fortunate in Virginia to be able to spend $8 million in the summer of 2018 when we first released the action plan to complete some initial pedestrian crossing projects. We focused this funding on projects that were low cost but high benefit, such as rectangular rapid flashing beacons and high visibility crosswalks. And we also looked for projects that were shovel ready and could be delivered quickly because we wanted to get some improvements in place that we could begin to evaluate and hopefully further the mission of the PSAP. We had overwhelming interest with $43 million worth of projects submitted for that $8 million in funding. And we funded 25 projects that are being completed as we speak. In addition, about a year ago in the fall of 2019, we got approval for another $25 million that's being used to upgrade pedestrian crossing infrastructure and all VDOT traffic signals that are on the PSAP priority corridors. And that work's going to be done over the next 4 to 5 years. So with that, that's all I have for you today, and we'll be turning things over to Stephen Reed.
All right, thanks, Mark. Stephen, the screen is coming to you. Let you know when we've got your slides. All right, you're all set.
All right, turn my camera on. Yes, thanks very much, Mark. So we were excited to be able to use that Health Opportunity Index to drive our safety program, to look across the network and systemically look at where we can improve that network with low-cost safety improvements. What I'm going to talk about now for a few minutes is how we wanted to really drive that decision-making tool into prioritizing for all of our projects, all of our capital projects. And that process in Virginia is called Smart Scale. Back in 2014, we had legislation that required us to be more data-driven with performance measures in terms of assessing and prioritizing where our transportation dollars are spent. This was branded as Smart Scale in 2016, and it's a process that we go through every 2 years. So we're actually this fall into round 4 of assessing our call for projects. So what does Smart Scale mean. It's of course system management and good allocation of our resources, but the scale is what I want to talk to you about in terms of safety. Nicely, we have safety as number one. And so we have a safety score that is given to every project, as well as improvements in congestion, accessibility. In our urbanized districts, we look at land use coordination, and then actually E in the scale is a double E for environmental quality and economic development around in the sites that are adjacent to that construction project. So focusing on safety, we wanted to bring this idea into the process, which looks across the range of different project types, whether it be just a purely highway project or a highway project combined with transit and rail, or bicycle and pedestrian, or with travel demand management, such as park and ride lots or ride share initiatives. And so working with our sister agencies at Department of Rail and Public Transportation and the Office of Intermodal Planning and Investment, we look at each of these projects that are submitted by our localities and our metropolitan planning organizations to understand whether or not it's meeting a need. And that's what we call project screening. And that's where we saw the best opportunity to use this PSAP information. And then, of course, I'm going to talk to you a little bit about how we evaluate and score these multimodal projects, and then how they get prioritized for programming. Safety needs are identified in our VTrans, medium and long-term transportation plans. And it looks at 4 types of networks. One are our major corridors of significance that run across the state that are multimodal, mostly following our interstates and our US routes. Then there's regional networks within our MPOs and TPOs, and then urban development areas within those, again, that are smaller areas. And of course, safety covers everywhere and is available for funding across our construction districts. So within VTrans, we developed a methodology for the first time in this last 2-year update for our call to projects to identify those midterm needs in terms of the pedestrian risk using the PSAP. And so within the methodology report, we explain here how we added in the PSAP and the actions that we took to include that as a given need within each construction district and therefore jurisdiction in the Commonwealth. All of this information was mapped again on top of all of the other needs. And so here's an example here in the Richmond Transportation Planning Organization area boundary with the network. And you can see highlighted, I've identified a midterm need that is for pedestrian safety improvement. So when this was all developed last year, we had the original PSAP corridors, that top 1% that Mark talked about. And those are the corridors that are highlighted in the light green, bluish green color here on the map. And so applicants, the localities, the MPOs could look at these maps and look where different needs overlap, including the pedestrian needs for the first time. In the past, they basically relied on sort of a gap analysis of where they had needs in terms of accommodations for the non-motorized. And so projects are submitted through a smart scale portal that we have, and all of these layers are mapped again, and the applicant can zoom in on a corridor and identify the needs that are on the corridor that they're interested in. This is a safety improvement for some sidewalks here in the city of Richmond that's actually about perpendicular to one of our PSAP corridors in the city. So it's touching the end of it, but and addressing perhaps there at that intersection, but is moving along from it. And so this is where we would look to see are needs being addressed, and have they touched one of those VTrans needs in terms of identifying the issues for safety, congestion, accessibility, etc. And so that information on the portal is used for project screening and whether or not we've identified a need. And once they're screened in, then it comes to work groups in each of those scale measures to calculate the effect or the benefit of the project, and it's scored. And that project list is sent to our Commonwealth Transportation Board, who looks at that prioritized list and makes the funding decisions every other year to add new projects. So what we're looking at is actually prioritizing projects in year 5 and 6 of our 6-year improvement program for those capital projects. In terms of scoring for safety, we're actually looking at the benefits of that project by applying crash modification factors, which is essentially the complement of the crash reduction. If you will, if there's a 20% reduction in crashes, then the modification factor is 80% or 0.8. And so we have used several sources, federal sources as well as international sources when we don't have factors from here in the US. And we looked at the different categories of those, which for purposes of this discussion, we're focused on the bicycle and pedestrian reductions, which Mark mentioned is at the back end of the PSAP document that's online. And so for every project, we segment that project and we look at the different improvements or countermeasures that are being deployed along that corridor or at that intersection. And we want to identify all of those reductions that are being added. And so we try to split it down to the smallest final segment that would have one or more of these modification factors applied. So you can see here that potentially you could have lighting that's added or to fill a gap in lighting that would address nighttime crashes, but also the sidewalk that would address non-motorized crashes, as well as widening the road, which would include, the improvements to the roadside because of that sidewalk project. And so with each of those segments and applying all of those crash modification factors, we can get at the benefits that we would expect in terms of the reduction of those crashes. And that is done for every project. So we have, from our PSAP, identified the best available factors and values. And you can see here a value of 0.12 or a 88% reduction in bicycle and pedestrian crashes by adding a new sidewalk. And then here's some application of that in terms of when we would apply that to a project, in terms of it being a new facility and potentially, improving the roadside and moving those fixed objects like the trees you see in this picture away from the travelway that would improve the vehicular traffic safety as well, which we accommodate in terms of what we call a roadside hazard rating. So with all of those factors applied to all of the projects, we come up with a reduction in benefits, and then that is normalized within each score and then normalized by the project cost. So it's not a true benefit cost for the project, but it is sort of the project benefit score divided by the cost. So the number of points, if you will, per dollar spent. And so each project is given a scorecard. So here's an example of a project that was widening a highway and then adding a 10-foot shared use path along one side of the road. And so when you look at the scores for safety here, you can see we have two measures. One is the reduction in the weighted value of the severity of the crash, called equivalent property damage only weighting. And we looked at the reduction in that number or frequency, as well as the reduction in the rate of that, which is divided by 100 million vehicle miles traveled. And so those scores are normalized out of 0 to 100, from the lowest score to the highest score. So you can see this project only received a 2.3 and a 1.0 for each of those under that normalized measure score, which is right here. And then those were previously weighted 50%, 50% for this round. That will be 70-30 for the number and then the rate. And that factor is factored up to a value and then given a final weight for each of these score areas. So in this region, the safety score is given a 30% weight to give it a final score. So even though this was actually a fairly low scored project compared to all the other safety scores and got a final weighted factor of 0.5, it was almost half of the total project benefit score. So even though it was a widening, it did not get a huge congestion mitigation score, but it did get a lot of points also under economic development. And so you can see there that the score is divided by the cost to get the number of points per $10 million spent. So that 2.2 was the final score. And you can see on the left side of the screen how it ranked within the state and also within the districts for those two different pots of money that were identified earlier when I talked about the networks. And so with this, we're able to bring through the PSAP work, which includes the Health Opportunity Index, through the screening and also through the scoring in terms of the expected crash reduction. It may be at some point in time we will add more direct health measures like the Health Opportunity Index or some other equity measures. But at present, those scale measures are what we have through as legislated here in Virginia. And so with that, I want to give ample time for you to understand the HOI in a little bit more detail. So I will stop sharing and turn this over to Justin.
All right, thank you, Stephen. Justin, we're coming to you next. So I sent you the screen. I'll let you know when we're up and running with your slides. All right, looks great.
Perfect. All right, great. Thanks, John, and thank you, Mark and Lauren, for that great introduction. I'll dive right in here. My name is Justin Crow. I am with the Office of Health Equity in the Virginia Department of Health. I'm going to start by giving a little bit of background on what an Office of Health Equity is and what it does in a Department of Health. Our mission is to identify health inequities and their root causes and promote equitable opportunities for residents of the state of Virginia to be healthy. Our office consists of 3 federally designated state offices. That is the State Office of Rural Health, the State Primary Care Office, the Office of Multicultural Health and Community Engagement. So we take a broad look at health disparities, race, ethnicity, geography, education, and income, and try to identify vulnerable populations generally. My division is the Division of Social Epidemiology. We provide a variety of data and research support to those 3 offices, the Virginia Department of Health generally, and our partners and stakeholders in state government and throughout the state. Just a basic idea about how we fit into creating health equity. This is a framework, sort of a visualization created by the Centers for Disease Control and Prevention on achieving health equity. It includes a focus on a policy that supports population health programs, which are the programs run by those federally designated offices I mentioned earlier, as well as our partners and stakeholders. And then our role is measurement data practices to support the advancement of health equity. What we really try to do in our office is focus on what we call actionable research or applied research. So we try to provide, we talk about providing information with impact. We hope to inspire our stakeholders and partners to take actions that improve the lives of vulnerable Virginians. And one of the things we do really is try to prioritize and target resources towards the populations that need them most and the factors that will best improve health within those communities. So one of our major tools for doing this is the Health Opportunity Index, and thank you, Mark and Sean, for demonstrating one of the uses of the Health Opportunity Index. We use the Health Opportunity Index to identify areas and populations that are most vulnerable to adverse health outcomes based on the social determinants of health. To develop the Health Opportunity Index, initially we had viewed this as an internal tool used mainly by our office, the Office of Health Equity, the Virginia Department of Health, the central office, as well as our local health departments, which are spread throughout Virginia. We have 35 local health departments which administer programs throughout Virginia, and a few of our stakeholders. So in order to build up the Health Opportunity Index, we created a work group of mainly internal stakeholders who identified those social determinants of health that they thought were important to health. We made sure that each of those were linked to health outcomes in the academic literature. Now, this didn't have to be a definitive link. Sometimes there's a debate about or mixed evidence about a link to health outcomes. One good example is the Gini Index, which measures income inequality. There's a lot of variation in outcomes that you see in studies, with some showing a definitive link and others showing less of a link, and really a lot of debate on what scale is the proper way to measure. But for our purposes, having just enough evidence in there that there was a link, we were able to leave income inequality in and not basically exclude factors based on that. But for most of these, there is a robust academic literature discussion for them. We tried to construe each of these indicators, each of these factors in a way that's actionable. A lot of discussions of health outcomes focus on race and ethnicity. However, we know it's not race and ethnicities that causes worse health outcomes. It's racism. So we focus on a measure of segregation, which I'll talk more about in a bit. And we needed consistent quality data for all census tracts in Virginia. We didn't have that for everything we wanted. We wanted to include a measure of crime, for instance. However, not all of our police departments in Virginia were able to provide data at the census tract level for us to include that. Okay, so what we ended up with was 13 indicators. These are constructed of 30 variables, which we then combined into 4 profiles, and then finally into 1 health opportunity index. Again, these are the 4 profiles. I'd like to point out that these were identified not subjectively. We identified these using statistical measures to see which of our 13 indicators tended to vary together. We used a statistical tool called principal component analysis. And then we sent out a survey to our stakeholder group and our office team to kind of name those profiles once the indicators were grouped. So these are the 4 profiles. The 13 indicators that go with each of them are listed here, and I'll go into a little more detail into each one of these. So our community environmental profile really looks at the built and natural environment. It includes an air quality index from the Environmental Protection Agency, a broad-based air quality index. A population turning index, which looks at the stability of the population within a neighborhood. our population weighted density index, which is really a measure of urban, rural, and suburban density, but you always see pockets of density in rural areas and low density in urban areas as well. So there is a lot of variation even in small areas. And then a walkability index, we use what's called the 4D method. I'm sure you are familiar with some of the standard measures for walkability. A consumer opportunity profile really looks at the access to consumer resources within an area. It includes our affordability index, which is housing costs and transportation costs divided by average income. An education index, which looks at the average years of schooling of the adult population. It always try to point out that this doesn't look at the quality of the schools in an area. It really looks at the educational level of the adult population within each census tract. Food accessibility index, which uses the U.S. Department of Agricultural food desert measure, which looks at the low-income population within an area and their access to a major grocery store. And finally, a material deprivation index, which includes a combination of unemployment, autoless homes, home ownership, and overcrowding. Now, this is really a look at the ability to accumulate wealth and access credit within each census tract. Our economic opportunity profile includes an employment access index. This looks at the number of jobs within the census tract and jobs that are nearby, and uses an inverse distance weighting function to measure the distance of jobs. So a job in the census tract might be worth might be counted as one job, whereas one that's, say, 100 miles away might be 1/10 of a job. That's just some example numbers, not what actually the actual figures used. We do include, as I discussed earlier, a measure of income inequality. The Gini coefficient is what we use, and a job participation index, and that is the civilian labor force as reported by the Bureau of Labor Statistics. And then finally, we have our wellness disparity profile. Now, this includes our access to care index and our segregation index. This was the weakest correlation we saw within our factors, but it was still a significant factor. So it is our still included as a profile here. So our access to care index includes a measure of the uninsured population in Virginia. Now this is data from 2015, so prior to Medicaid being expanded here in Virginia, so that data has probably changed quite a bit in the interim. And then access to primary care physicians within the census tract, and then a segregation index, which looks at race and ethnicity and interaction. If you're familiar with measures of segregation, is a spatial dissimilarity index done at the metro level. Okay, so our goal here was to be able to identify areas most in need of health interventions. So we wanted it to correlate with health outcomes, and it does. We find it across a range of different health outcomes. These are sort of some of the standard broad measures of health outcomes, life expectancy at birth. This may be a bit hard to read. We do score each census tract in Virginia and divide those into quintiles. So our very low opportunity to live a long and healthy life is how we say it, is our very low HOI, and our very high HOI at the other end of the scale, very high opportunity to live a long and healthy life. There is about a 5-year difference in life expectancy between those two groups, which is pretty large. Of course, there's a lot more difference within, between those groups and individual census tracts. Looking at what we call disability-free life expectancy, or years of healthy life, really, you see a 9-year difference between our very low opportunity tracts and our very high opportunity tracts. We see sort of the same pattern with different measures of mortality. So this is just comparing cancer, heart disease, measures of cerebrovascular disease, and unintentional injuries. We see a very similar pattern. Of course, just having those averages doesn't substitute for a good statistical analysis. Here in Virginia, a lot of times Northern Virginia, when you're looking at social determinants and socioeconomic factors, kind of stands out. It's a very dense area of the state, and the economic profile of Northern Virginia is very different than other areas of the state. So we either like to examine regionally or include some kind of spatial analysis. So this used a spatial regression. My colleague Rex Anton-Fuamana perform that, and if you just look at the adjusted R-square here, explains about 60% of the variation in disability-free life expectancy between census tracts. So back in, I believe it was 2017 or 2018, our colleagues got in touch with us from the Richmond Health Department, and I think Sarah Shaughnessy, a colleague from the Richmond Health Department, mentioned this in her presentation 2 years ago, the work we did with their Vision Zero program. And we were surprised at the time, but of course it's been further validated at this point that the Health Opportunity Index does correlate also with fatality and injury rates within the greater Richmond area. So you just focus on this sentence right here. Areas in the city with a very low HOI experience a fatality and injury rate 2.65 times higher than areas with a very high HOI. So that's a pretty significant increase. If you saw Sarah's presentation a couple weeks ago, she linked a lot of the information in her presentation to historic redlining. We were surprised, but I guess we shouldn't be because this probably represents sort of historic and chronic disinvestment in those areas. We do try to use this as a targeting tool and a prioritization tool to some extent. So we want to identify the neighborhoods that would see the most benefit from program interventions, and also try to begin the process of identifying the types of programs or the factors that need to be addressed, at least looking at the 13 within our Health Opportunity Index. So we do really on a local level, we look at the contribution of the individual HOI indicators on various factors. So this one looks at life expectancy in Portsmouth, and what we found is just ranked here is that the Townsend Material Deprivation Index has the highest impact, the largest impact on life expectancy, followed by population density, education, income inequality, healthcare access, and employment access for life expectancy. So if you're in Portsmouth and you're looking to address your vulnerable communities in that area, these are the factors that you may want to address in various ways. Of course, we then map that out. This was the same study, but a slightly different look, comparing our education index to diabetes rate per 1,000. And so you can see if we map that out, you can see in the lighter color, the lower opportunity areas in the sort of southeast area here, and you can see the percent of the population with diabetes in these larger circles. So this gives a program that's focused on diabetes prevention an idea of where to focus their resources to get the best return on their investment and their time. Of course, there are, with any project like this, limitations on what the HOI can do. There are data limitations. I mentioned we weren't able to include crime earlier, and some other factors that we had to leave out due to a lack of data. We mentioned the ecological fallacy here a lot because of the potential for misuse or inappropriate use in the clinical setting, but individuals within different census tracts, even if they're in a lower or high opportunity census tract, may experience have very different experiences. Related to that, census tract, we use census tracts identified by the U.S. Census Bureau. They tend to have a population of around 5,000, somewhere between 1,500 and 8,000 is the usual population size, but usually around 4,000 or 5,000. That does not necessarily equal a neighborhood. There can be a pretty large differences within a census tract between, if you look at different areas within a census tract. just about all of our measures to get a census tract level estimate that's valid. We use 5-year estimates, so it's not exactly timely. The HOI that we're using now was last finished in completed in 2015. We are planning to update it when the new census tracts come out in, following the 2020 census, which should be concluding fairly soon. But the data may not always be timely, but it should be relatively steady, at least as well. It is a statewide measure. We like to point out that it is a broad statewide measure whenever doing a local analysis of SDOH. It's always good to dive in and meet with the community and discuss some of that community engaged research that was mentioned earlier. And with that, I'll be happy to answer any questions.
Okay, well, thanks so much, Stephen, and to the entire panel for your presentations. I'm going to pull up a slide here that I'd like to show during our Q&A period, which is going to be moderated by Sagar Shah. So Sagar, as I get set up here, go ahead and start working through those questions with the panel.
Yeah, sure. Thank you, Dan, and thank you all for such great presentations. I really like the work that you do. I'm going to definitely use this example a lot now in the talks, in the work that I do, but also while talking with people. So highlighting the great work that you all have done. So with that, I would directly dive into the questions that have been asked by some of the participants. And if there is some time, I have my sort of 10 questions right now for you all, so we can go there, but let's start with what have been asked in the chat box. So the first question I'll ask Mark, that early on in the presentation you described safety issues identified with lack of crossings, and it was clear that subsequent projects improved crossings that were deemed unsafe. What methods do you use to determine where to place new crossings rather than improve those that already exist but need reinforcement?
That's a really great question. So in Virginia, we have a couple of policy memos that guide installation of crosswalks. And so included in our policy recommendations of the PSAP were recommendations to strengthen those policies. So we've actually been working with our consultant VHB to improve our policy memo that focuses on unsignalized intersection crossings. So everything from mid-block crossings to unsignalized intersection crossings, we're working on that policy update right now. And generally the way that is going is where you meet a basic safety check of things like sight distance and spacing between crosswalks. Then our plan is to shift the policy in a direction of providing a crosswalk where we know we have pedestrian travel needs and those safety checks are met. The PSAP also helps us greatly with that because we know the highest risk locations based on the analysis. So that is also a factor as to whether we require a new crosswalk or not. So hope that helps to address your question, but also just the fact that so many of our crashes were occurring where we didn't have a marked crosswalk has helped us already to divert our funding to go ahead and start making improvements at those locations. And VDOT traffic signals is one of the first benefactors of that change in and how we approach pedestrian crossings.
Thank you, that was helpful. I think it did answer the question. The next question is for Stephen. You in your presentation mentioned roadway widening, sidewalk, having new sidewalks, and then doing lightning projects. Would there be a mechanism to determine whether the widening aspect of the project might have an impact on the overall pedestrian crash risk? Because I think sort of the person is asking about unintended consequences that comes with doing all these projects. So what do you say to that? So for example, the person mentioned that it seems the widening could increase the crossing distance, right? Or would potentially influence driver speed, for example. So is there a way to capture this anticipated or unanticipated impacts on risk during the scoring exercise?
Yeah, so we've been fortunate to be able to get some research, I'd say in the last 10 years on these non-motorized, effects of benefit, the crash modification factors. What I'm finding with the studies and research that's going into them is it's difficult to identify the interrelationship that's going on with other factors. And so, like for the smart scale that we're doing right now, we're kind of considering them all independent, and then we're multiplying the effectiveness of each of those. So if there's 3 CMFs, we're multiplying it, 1, 2, 3 through that. But some of those interdependencies and interrelationships are not really captured yet in the research. There is a large research project going on right now that's looking at predicting non-motorized crashes. And they're looking at how to do that with, if you have lots of data about the infrastructure and the travel patterns, non-motorized and vehicular, and when you don't have so much data. And so we're really hopeful that that research would allow us more at the, not at the planning level that we're doing now, but at the project level to look at some of those trade-offs. So we're not quite there yet, but we're hopeful for this new NCHRP project to be able to help us move down the road in terms of those relationships.
Okay, perfect. Thank you. The next question I'll ask Justine, and this is my question. I'm really interested in this. I'll ask you, and maybe Lauren, you can jump in as well. Mark presented that when they changed in 2019, when they changed the weights, the one thing that struck to me was that no vehicle ownership households was included into the highest weight criteria, and then the poverty percentage or poverty density, I think, was almost removed in 2019 because it was not sort of significant enough. Justin, do you think that considering that the health index was added that took care of the socioeconomic characteristics, etc., including poverty? I'm just surprised because I've done at 2 different regions. I've done analysis on no vehicle ownership and poverty, and in both places there was like strong correlation, like above 0.85, 0.9 relationship between both of those, and it seems like here it is not, or maybe it is. So do you think the LOI took care of that particular aspect? Oh, Justin, we can't hear you. Justine, we can't hear you. Can you unmute if possible?
Sorry about that, Justin. We seem to have lost your line for the moment. I'll see if I can work on that.
Yeah, I think Stephen wanted to say something. I could see Stephen and Lauren both like say something. Maybe I misinterpreted something. So please jump in.
Stephen and Mark, I think I can probably, it wasn't that poverty was not significant. In fact, the HOI, like you said, Sagar had such a strong relationship. It was very similar, in fact, to the relationship to poverty. So the question really came down to, did you need both as risk factors?
There is one. Justine, are you back or?
Yes. Hopefully. All right, great. I have no idea what I did.
Yeah. Question for you is, can you expand upon how you calculated the walkability index within HOI? Because I have seen in research there are people using like walk score, but there are limitations with walk score and there are different things. Actually, my dissertation, I calculated walkability index as well, and there was like a huge I had a huge complaint against all the 4Ds or the 5Ds that we use in walkability. But yeah, I'll let you explain. How did you calculate walkability?
We use a basic, walk score. I'm not sure. I can't really expand on the details of what goes into it now, but we did use a 4D walk score, a pretty standard measure. We didn't try to go out on on a limb when we created it or when we selected it, but it was a pretty standard walkability score.
Yeah, I agree. I think that makes sense because considering that you are working at state level, I mean, if you're working like neighborhood level, maybe you can do zoom down at a finer scale and think about other factors. But at state level, you are using the data that is available. So I think that makes sense in terms of looking at census tracts and looking at access to food, access to density, access the site, the street intersection density, et cetera, the 4Ds. So I think it does make sense. So I'm going to ask the next question to Mark. Now that the state has adjusted its method for ranking and scoring these projects, have you, or Stephen, you can answer as well, seen a change in the type of projects that are submitted to the state for funding? How has the state engaged local agencies, MPOs, and others to communicate how the changes might impact how projects are scored? So two-part question. First one is about have you seen the change in the types of project? And the second one is about how did you engage local agencies and MPOs to inform them about the changes?
Mark, do you want to take the HSIP side of that, and I'll talk about Smart Scale?
Yeah, that sounds good. So first off, the creation of the PSAP has coincided in Virginia with a change also to more systemic projects. So 5 to 10 years ago, if you were applying for a safety project in Virginia for funds, you were likely trying to do a spot project and maybe do a road widening or a long sidewalk project. These days, we don't fund many of those kinds of projects. So most of our safety projects now in Virginia, and certainly our pedestrian safety projects, are focused on lower cost, high benefit treatments that can be deployed across a city or a town or a whole network to try to have a bigger impact. So that's been an education process that we've been going through with localities currently. Also, based on our couple of initial PSAP projects, the majority of that money, so that first $8 million we talked about, the majority of that went to local governments. The $25 million investment last year, all that went to VDOT traffic signals. So we are currently awaiting new funding that will hopefully come as a result of a new transportation bill in Virginia that passed this year in 2020 that will give more opportunity for these types of projects for both VDOT and localities. So we'll have a major outreach effort for that. Stephen may have something to add about Smart Scale.
Yeah, most certainly. There has been a huge push to educate our localities and our MPO agencies in terms of how they would get success in terms of the scoring of those scale measures. And so within almost every one of them except economic development, there is a non-motorized component to the score. So there'll be a safety benefit, obviously. In terms of congestion, everything is measured in terms of person throughput. So adding facilities and accommodations will help with the congestion score. It's part of the accessibility, which is turned over into the accessibility score in terms of accessibility to jobs, from the households, as well as some of the mixed use land use scores that are incorporated when you're in one of the more urbanized regions that gets that land use score. So all the way along, we've been telling people the more multimodal you are, the higher score you're going to get, and that's completely changed the landscape of projects that we're seeing. And also to just pivot back to the question about the safety benefits of widening, versus the sidewalk or shared use trail and crossings. With all of that, we're actually seeing less widening projects and more sort of corridor optimization with innovative intersections, signal timing projects, improving the flow, without a lot of widening. So more localized improvements with innovative intersections, and then adding that bike and pedestrian component so that they get scores across all of the measures. So yeah, we've really seen a paradigm shift because of all of this for all of our capital improvements. And of course, there's still the Highway Safety Improvement Program funds and our TAP funds with transportation alternatives as well, that are prioritized separately.
Thank you. Dan, I know there is 1 minute. Is there time for one more question, or should we
Sure,
wrap up?
go for it, Sagar. Yep.
Yeah, just to ask an easy question, but this is personal interest. Like, how did the relationship between VDOH and VDOT started? Like, was it already established and you started working? Like, how did you guys start talking with each other? Anyone?
So I can take a shot at that. So Sarah Shaughnessy, who was a prior presenter, she was introduced to me by the city traffic engineer at Richmond, and I was told that I need to see this analysis that she had done using this thing called a health opportunity index. So we had a meeting, we saw it, it kind of blew our mind. We're like, hey, this is awesome. And so right away, we then reached out to Department of Health and have made some great contacts there that I think that's continued as time has gone on. But really, we just can't be more excited than to have learned about the HOI and have built this relationship with Department of Health and to be using that in our highway safety efforts and in the pedestrian safety realm has just been great so far.
Yeah, that's an amazing example to like, because there are many times I hear the cases like, well, we had like established relationships in 10, 15 years, but this is good that, yeah, two people met and then led to other things, and it's the ball is rolling since then, since 5 years. So thank you so much, and I'll hand it over to you, Dan, for the
Thanks. Well, I thank you all so much for your time presenting and responding to those questions. We could probably go for another half hour if we have the time. I hope that if you do have remaining questions, you can reach out to our panel. I'm trying to provide their contact information in the slide deck. Let us know if you have questions, but I just want to say thank you once again to Sagar, Lauren, Mark, Stephen, and Justin for their excellent presentations today. Thank you all for joining us. I hope we can see you tomorrow for our final episode in this series. I'll have an email coming to you later today with some final links, wrap up, and all that. So once again, thanks everybody, and we'll see you next time. Thank you.
Thank you. Bye, everyone.